So welcome, guys. In today's session, we'll be looking at cholinergic agonists. This is under autonomic nervous system, and so welcome all. My name is Oris Winyeri. As always, I'm the Yule Doctor. Now, let's start with an overview. The drugs which are usually affect the autonomic nervous system are usually divided according to the type of neuron involved in the mechanism of action. So, those that affect cholinergic neurons, they are cholinergic drugs. Those that affect adrenergic neurons are adrenergic drugs, and they can either stimulate the nerve or inhibit it. So those that stimulate can either be are the agonists, and those that block the receptors are antagonists. So you can have cholinergic agonist and cholinergic antagonist. So the other name of cholinergic agonist is cholinomimetics. So cholinergic antagonists are your cholinolytics. Okay, your adrenergic agonists are your sympathomimetics. They mimic the effects of noradrenaline at the receptor. You also have a sympathetic antagonist, your sympatholytics. Okay, so those four classes of drugs, when discussing the autonomic nervous system, you must understand them. So let's start with the direct acting cholinomimetics. Acetylcholine. It is the natural. It is naturally occurs in the body. BETHANCHOL, CARBACHOL, cevimeline, methacholine, nicotine, and PILOCARPINE. We'll be focusing mainly on this. Then indirect acting include your hydrophonium, neostigmine, and physostigmine, just to mention a few. Then indirect acting but irreversible, these are the reversible ones, include ecothiophyte and other organophosphates. Then we have drugs that are used to reverse the effects of organophosphates before aging occurs. You will learn what aging is if you haven't. And they include pralidoxime. Now let's start with first cholinergic neurons. Now, cholinergic neurons include the preganglionic fibers to the adrenal medulla. You can see here they are using acetylcholine. Then also preganglionic fibers to both ganglion, either at the sympathetic and parasympathetic, and also the somatic nerves use acetylcholine at the neuromuscular junction. Also, we have acetylcholine is used as the neurotransmitter at the neuroeffector junction in the parasympathetic nervous system, and also at the neuroeffector junction of the sympathetic nervous system to the sweat glands. We also use acetylcholine. So please understand that. Then let's look at neurotransmission at these neurons. Neurotransmission at these neurons involves 6 steps. The first step is the synthesis of acetylcholine, where we take acetyl-CoA and choline. Then acetylcholine is made from the two, and a reaction catalyzed by the choline acetyltransferase. Okay. Then once acetylcholine is synthesized, we need to uptake it into storage vesicles via the vesicular amine transporter, or is it the vesicular associated transporter, VAT, which is inhibited by vesamicol. Please don't confuse vesicular amine transporter with the vesicular monoamine transporters, which are found in the adrenergic neurons. And the vesicular monoamine transporters, VMAT, are usually inhibited by resapine. But in this case, VAT, vesicular amine transporter, is inhibited by vesamicol. Okay. Then the third step is the release of neurotransmitter. How does that occur? Once the actual potential arrives at the synaptic vesicle, it will cause calcium influx, okay, and this will cause exocytosis. Now, for this process to occur, you must have interaction of the fusion proteins found on the vesicle and the presynaptic membrane. Those found in the vesicle are known as the vesicular membrane associated transport transporters, VMAT, usually, VAMPs, sorry. Those on the vesicle are known as VAMPs, the vesicular associated membrane proteins, whereas those in the presynaptic membrane are known as SNAPs, synaptosomal neuron associated proteins. I don't know why membrane proteins. You have SNAPs and VAMPs. Those are your fusion proteins, and they are usually deaminated by the botulinum toxin, and this will prevent acetylcholine release. Sorry for the small confusion. Then we have autoreceptors on the presynaptic membrane. Okay, notably, you can see them. Then acetylcholine, the fourth step is binding to the receptor, cause action. Then it is usually degraded by acetylcholine, and this is where the acetylcholinesterase inhibitors act on the indirect acting cholinergic agonist. Then once we degrade it to acetylcholine, choline is taken back to the synaptic vesicle by the a transporter known as the choline transporter, which is a sodium choline cotransporter, and it is usually inhibited by hemicholinium. So let's continue. Then cholinergic receptors are of two types. The cholineceptors are two types, can either be muscarinic or nicotinic. Now muscarinic, there are 5 types, M1 through to M5. Now those which have odd numbers, that is M1, M3, M5, they are GQ coupled, in that the activation of these receptors will lead to activation of phospholipid C with subsequent increase in intracellular calcium due to the action of IP3, and also activation of protein kinase C due to the action of DAG, diacyl glycerol. Now, nicotinic, then M2 and M4, they are GI coupled, in that the activation leads to inhibition of adenylyl cyclase and subsequent reduction in cyclic AMP, and also increased conductivity to potassium. Okay, and I want you to go and know their respective locations, but M1 is found in the CNS, some presynaptic sites. M2 myocardium. Also M1 notably is found in the gastric parietal cells. M3 mainly in the exocrine glands. M4 in the vagal nerve endings. Then M5 in your vascular endothelium of the cerebral blood vessels. Then nicotinic, they are of two types: nicotinic neuronal, nicotinic muscular. Nicotinic neuronal, both of them are ionotropic. They are ion channels. Binding of acetylcholine causes opening of the sodium potassium channels, leading to depolarization. Now, I have skipped direct acting cholinergic actions, agonists, sorry. Now, cholinergic agonists usually mimic the effects of acetylcholine by binding directly to the cholineceptors, and they are usually classified into 2 groups. Let me take a pen. Sorry, don't know what. Sorry. Now, they are of 2 types. They can be either choline esters, and choline esters include acetylcholine itself and the synthetic esters of choline, such as CARBACHOL and BETHANCHOL. Now, you also have naturally occurring alkaloids, okay, which will include nicotine and PILOCARPINE. Okay. Now, all direct acting cholinergic drugs have a longer duration of action than acetylcholine because they are resistant to degradation by the acetylcholinesterase enzyme. Now, the more therapeutically useful drug, that is PILOCARPINE and BETHANCHOL, they are selective in that they bind to muscarinic receptors rather than both muscarinic and nicotinic. But drugs such as CARBACHOL, okay, bind to both muscarinic and nicotinic, and this will limit their clinical usefulness and utility. Here you have the structure, which I will not bother you, but bethanical and carbachol both are esters of carbamic acid. Then you have another drug known as methacholine, which is the other name of methacholine is acetyl beta methylcholine. Okay, so instead of having a hydrogen here, methacholine usually have a CH3 group here. Okay, okay, and methacholine also is it is selective in that they bind to muscarinic receptors rather than both. Now, acetylcholine, it is a quaternary ammonium compound and cannot penetrate membranes. Remember that. It has both action at the, it has ganglion action, okay, and also muscarinic action, and also at the neuromuscular junction. Okay, now it has both muscarinic and nicotinic. That is what I'm trying to explain. What are its action? One, it will decrease heart rate and cardiac output. Its action will mimic those of vagostimulation. For example, if injected intravenously, which isn't done, it will produce a brief decrease in cardiac rate, bradycardia, and cardiac output, because it will reduce the rate of firing at the sinoatrial node. So it will act on M2 receptors in the sinoatrial node. Okay. Now, it also decreases blood pressure in that it causes vasodilation and lowers blood pressure by an indirect mechanism in that when it binds to the M3 receptors on the endothelial cells, it will cause release of nitric oxide from those cells, the endothelial cells, and this nitric oxide usually diffuses to the vascular smooth muscles and stimulate protein kinase G, which leads to hyperpolarization and smooth muscle relaxation via phosphodiesterase 3 inhibition. Also, note that in absence of administered cholinergic agents, the vascular cholinergic receptors have no known function. Why? Because cholinergic is not, acetylcholine is not a hormone, and rarely will it be released in blood in significant quantities in normal physiological processes. Now, atropine is usually an antimuscarinic agent, and it will prevent acetylcholine from producing vasodilation. So, in case of acetylcholine overdose, you can use atropine to reverse these effects. Other action in the GIT, it will cause increased salivary secretion, also increase gastric acid secretion. It will also stimulate intestinal secretion and motility. It also enhances bronchial secretions and bronchoconstriction. So you cannot, it is contraindicated in asthmatics. You cannot go to use this in asthmatics. Now, methacholine, which is a direct acting cholinergic agonist, is used in the diagnosis of asthma due to the bronchoconstricting properties. And remember, it has selectivity for muscarinic receptors. Okay, so it will act on these muscarinic receptors on the bronchial smooth muscles to cause bronchoconstriction. Now, in the genitourinary tract, acetylcholine usually increase the tone of detrusor muscle, so it causes detrusor muscle contraction, causing urination. Now, in the eye, it is involved in the stimulation of ciliary muscle contraction for near vision, okay, and constriction of pupillaris sphincter muscle using constriction of the pupil, that is meiosis. So it is a meiotic agent. Also, it is instilled in the anterior chamber of the eye to produce meiosis during ophthalmic surgery. Bethanchol is an unsubstituted carbamyl ester, which is related to acetylcholine, but it is not. It is a its action it is a long-acting cholinergic agonist because it is resistant to it is not easily hydrolyzed by acetylcholinesterase. Okay, but it lacks nicotinic action due to the addition of the methyl group. Okay. Okay, so it is selective. So it has strong muscarinic activity. It mainly acts on the smooth muscles of the bladder and the GI tract with a duration of action of about an hour. Actions it will cause if it will act on the GI tract, the smooth muscles. It will cause increased intestinal motility and tone. So it will cause gut hypermotility that can lead to diarrhea as a side effect. It also stimulates the detrusor muscle of the bladder, whereas the trigone and the sphincter muscles are relaxed, causing urination. So urinary urgency can be a side effect. Its therapeutic use is it is used to stimulate an atonic bladder, okay, especially particularly in postpartum or postoperative non-obstructive urinary retention. So there must be no obstruction, okay. Also, bethanchol may also be used to treat neurogenic atony as well as megacolon. Now, adverse effects are generalized cholinergic stimulation such as sweating, that is diaphoresis, salivation. You can see these are just generalized cholinergic stimulations, flushing, decreased blood pressure with the defects tachycardia, nausea, abdominal pain, diarrhea because of the hypermotility of the gastrointestinal tract, bronchospasm because of its action on the bronchosmooth muscles. Now, atropine may be administered to overcome severe cardiovascular or bronchoconstrictor responses to these agents. So these are your side effects: diarrhea, diaphoresis, meiosis, nausea, and urinary urgency. Now, carbachol is the other, alongside bethanchol, it is the other ester of carbamic acid, and it has profound effects on both cardiovascular and the GI system because it has ganglion stimulating activity. It acts on both muscarinic and nicotinic receptors. So at first it may stimulate and then depress these systems. Now, it will acting on the nicotinic receptors found in the adrenal medulla. It will cause release of epinephrine. Okay. Then when locally instilled into the eye, it mimics the action of acetylcholine, that is, it will induce meiosis and spasm of accommodation in which the ciliary muscle of the eye remains in a constant state of contraction, sacroplegia. Okay, that is known as sacroplegia. So there will be loss. The person, the vision will become fixed at some particular distance. So there will be blurred vision. Okay. Atropine, on the other hand, usually causes mydriasis. We look at that. Now, therapeutic uses. Due to its high potency, it has also receptor non-selectivity and relatively long duration of action because it is resistant to degradation by the acetylcholinesterase. It will be rarely used. Okay. Now, intraocular use provides meiosis for eye surgery and lowers intraocular pressure in the treatment of glaucoma, but it is not the drug of choice when treating glaucoma because you have seen the adverse effects. But in ophthalmic use, there will be few adverse effects because it lacks systemic penetration. It is a quaternary amide, so it will not diffuse across the membranes easily. Now, pilocarpine. The alkaloid pilocarpine is a tertiary amide. Okay. So if it is a tertiary amide, it can cross the blood-brain barrier, and it is stable to hydrolysis by acetylcholinesterase. Now, compared with acetylcholine, which was a quaternary amine, and its derivatives, it is far less potent. It is less potent, but it is uncharged, and this will allow it to penetrate the CNS at therapeutic doses, so it can traverse the blood-brain barrier, unlike the others. So it exhibits mainly muscarinic activity, like bethanchol and methacholine, okay? And it is primarily used in ophthalmology. Now, action. Applied topically to the eye, it will cause, like just the others, meiosis, contraction of the ciliary muscle, and spasm of accommodation, sacroplegia, that is, and it is one of the most potent stimulators of secretion of the sweat to cause diaphoresis, tears acting on the lacrimal gland, salivation, but its use for production of these effects has been limited due to lack of selectivity. Now, where is it used? To treat glaucoma, and it is the drug of choice for emergency lowering of intraocular pressure in both open angle and closed angle glaucoma. How does it lower intraocular pressure? It will open the trabecular network around the canal of Shem and will cause immediate drop in intraocular pressure because of increased drainage of aqueous humor. Now, this action occurs within a few minutes and can last for 4 to 8 hours and can be repeated. But note we have other drugs which are used but not for emergency lowering of intraocular pressure, and these include topical carbonic anhydrase inhibitors such as dozoramide and beta adrenergic blockers, your timolol. Okay. Now, the meiotic action of pilocarpine is useful for reversing of mydriasis due to atropine. Okay, and it usually promotes salivation, so it is a cyaragogue in patients with xerostomia, dry mouth, resulting from irradiation of the head and neck, and also in Sjögren syndrome. Okay, then but we have another drug known as cevimeline, which is a quinacridine derivative of acetylcholine, but it has a long-lasting effects than pilocarpine and also fewer side effects. Okay. Now, what are the adverse effects of pilocarpine? It causes blurred vision, night blindness, and brow ache. Okay. Poisoning with this agent is usually characterized by exaggeration of various parasympathetic effects, which will include profuse sweating, diaphoresis, salivation, okay, also urinary urgency, okay, also there'll be nausea, okay, because it can traverse the blood-brain barrier. Now, these effects are similar to those produced by consumption of mushrooms of the genus Inocybe. Okay, so patient comes and tells you he or she got some wild mushrooms, cooked them, then ate them, then comes to the hospital and presents with meiosis, profuse sweating, salivation, urinary urgency, diarrhea. You will suspect that these mushrooms are from the genus Inocybe, and they contain mescaline, and this will produce this effect. Also, these effects, these symptoms are the same ones which will be observed in organophosphate poisoning, especially in farmers who who had the intentions of committing suicide, and they use malathion to take their lives but don't die. They present with those symptoms, and how you reverse that is you give an injection, a parenteral atropine, at doses which can close the blood-brain barrier, okay, so as to counteract the toxicity of pilocarpine. So I think we've come to the end. Thank you for your attention, guys, and please subscribe for more anatomy and biochemistry content. Thank you.